Your doctor has recommended a surgery. Maybe it was presented as routine. Maybe the word elective was used, as though elective means low risk. Maybe you were shown an X-ray, told your joint looks like this, and handed a referral to a surgeon before the appointment was over. What your doctor almost certainly did not tell you is what the long-term data shows happens to people over 60 who have these procedures. Not whether they survive the surgery, not whether the immediate recovery goes smoothly. What happens to their independence, their mobility, and their quality of life 6 months, 1 year, and 5 years later? I have spent years watching that data, and what I have seen changed how I counsel every patient over 60 who comes to me facing a surgical recommendation. Today, I am counting down 5 surgeries that are recommended to seniors every single day, covered by insurance without question, marketed as safe and life-improving, but whose long-term outcomes tell a fundamentally different story. I am going from concerning to the one that genuinely keeps me up at night. I'm Dr. Jake Taylor. If a doctor has recommended any procedure to you in the last year, write surgery in the comments right now. And stay with me until the end, because the #1 surgery on this list is performed on over 450,000 Americans over 60 every year, and most of them were never told what the research actually shows about long-term outcomes. Why the aging body changes the risk calculation for surgery. Before we count down the 5 surgeries, you need to understand why the same procedure that carries manageable risk at 45 carries a fundamentally different risk profile at 65 or 75. Without this context, the surgical risks I am about to describe seem exaggerated. With it, they are completely logical. After 60, 4 biological changes compound simultaneously to alter how your body responds to surgical intervention. Collagen production declines by approximately 40% compared to younger years. Collagen is not just a skin protein, it is the primary structural material in wound healing. Surgical incisions in a body producing 40% less collagen heal more slowly, scar more extensively, and are more vulnerable to complications during recovery. Immune function decreases by approximately 35%. Every surgical site is a potential infection portal. An immune system operating at 65% of its younger capacity manages that portal less effectively. Hospital-acquired infections, which are responsible for a significant proportion of post-surgical complications in seniors, exploit exactly this vulnerability. Circulation slows and blood vessels become more fragile. Oxygen and nutrients reach surgical sites more slowly, extending recovery timelines and increasing the risk of tissue complications. Fragile vessels increase bleeding risk during procedures and clot formation risk during recovery. Anesthesia tolerance changes. Research has consistently documented that anesthesia exposure in adults over 65 is associated with increased risk of post-operative cognitive dysfunction, a condition where mental clarity, memory, and processing speed decline following surgery. For open procedures requiring extended anesthesia, this risk is particularly significant. These changes do not mean surgery is never appropriate after 60. They mean the threshold for justifying surgical intervention should be substantially higher than it is at 40, and they mean that conservative alternatives deserve a genuine and thorough trial before an irreversible surgical decision is made. There is a 5th factor that rarely appears in surgical consultations, but that shapes outcomes in ways the recovery room statistics do not capture. After 60, the psychological and functional disruption of major surgery carries its own independent risk. Research has documented that extended post-surgical immobility in older adults initiates a cascade of secondary deterioration, muscle loss that begins within 72 hours of inactivity, bone density decline that accelerates during recovery periods, and the social isolation of extended home recovery that is independently associated with cognitive decline in seniors. The surgical risk calculation that your consultant presents focuses on what happens in the operating room and the immediate recovery. It rarely accounts for what 6 to 12 weeks of post-surgical restriction does to a 70-year-old body that took years to build its current functional capacity. Before we go further, I want to say something briefly. If this video is giving you information you have needed and never received, subscribe right now. We are a small channel doing serious work. Subscribe and let's continue. The 5 surgeries I would never allow a family member over 60 to have without exhausting every alternative. First surgery number 5, arthroscopic knee surgery for osteoarthritis. This is the procedure where a surgeon inserts a camera and instruments into the knee joint to remove damaged cartilage fragments and smooth rough surfaces. It is minimally invasive. It is logical sounding. Your knee hurts, the cartilage is damaged, so remove the damaged parts. The problem is that osteoarthritis is not caused by loose cartilage fragments. It is caused by the progressive deterioration of the joint itself. Removing fragments does not address that process. It does not slow it. It does not reverse it. The 5 surgeries I would never allow a family member over 60 to have without exhausting every alternative. First surgery. 5. Why knee surgery makes osteoarthritis worse. This is the procedure where a surgeon inserts a camera and instruments into the knee joint to remove damaged cartilage fragments and smooth rough surfaces. It is minimally invasive. It is logical sounding. Your knee hurts, the cartilage is damaged, so remove the damaged parts. The problem is that osteoarthritis is not caused by loose cartilage fragments. It is caused by the progressive deterioration of the joint itself. Removing fragments does not address that process. It does not slow it. It does not reverse it. A 2017 study published in the New England Journal of Medicine followed 351 patients over 45 with osteoarthritis who had arthroscopic knee surgery. 2 years later, they reported identical pain levels to patients who had received only physical therapy. The surgery produced no additional benefit over conservative treatment. None. But it added anesthesia exposure, surgical trauma, scar tissue formation, and in 22% of cases, patients reported their knee felt worse after surgery than before. The conservative alternative has documented efficacy. Targeted physical therapy strengthening the muscles that support the knee joint, glucosamine and chondroitin supplementation, anti-inflammatory nutrition, and weight management have collectively been shown to reduce knee pain by up to 38% within 3 months in osteoarthritis patients. Your body has a remarkable capacity to compensate and adapt when given the right support. Surgery interrupts that adaptive process. It forces the body into emergency repair mode when it should be in gradual strengthening mode. George was 66 and had been told by his orthopedic surgeon that his knee cartilage looked like a 90-year-old's on imaging and that arthroscopic cleanup was the obvious next step. He had been living with moderate knee discomfort for 18 months. When he came to me before scheduling the procedure, I walked him through the New England Journal study. He decided to try 6 months of structured physical therapy, glucosamine sulfate, and anti-inflammatory dietary changes before committing. At 6 months, his pain had reduced by roughly a third. He was climbing stairs without bracing himself against the rail. He told me, "The surgeon made it sound like I had no choice. I wish someone had shown me that study before the consultation." Surgery number 4, spinal fusion for lower back pain. Spinal fusion is a major procedure where surgeons permanently join 2 or more vertebrae using metal rods, screws, and bone grafts. The premise is straightforward: eliminate movement between painful vertebrae and you eliminate the pain. The reality is more complicated, and the long-term data is deeply concerning. Barbara was 68 and came to my practice 6 months after spinal fusion surgery in tears. Before her surgery, chronic lower back pain had made long car rides uncomfortable and limited her gardening. After surgery, she could not bend to tie her shoes. She could not twist to check her blind spot while driving. She had to sell her 2-story home because climbing stairs had become excruciating. Her surgeon had told her she would be good as new in 3 months. What he did not tell her was the biomechanical consequence of fusion that the research has documented clearly. Fusing vertebrae transfers mechanical stress to the joints immediately above and below the fusion. Research published in the Journal of the American Medical Association found that within 5 years of spinal fusion, 38% of patients develop significant problems in adjacent vertebrae, problems that often require additional surgery to address. A 2019 study compared adults over 60 with chronic lower back pain. Half received spinal fusion, half received intensive physical therapy, core strengthening, and pain management. After 2 years, both groups reported similar pain levels, but the physical therapy group maintained significantly better mobility, experienced 0 surgical complications, and avoided an average of $87,000 in medical costs. Barbara eventually regained approximately 60% of her pre-surgery mobility through months of targeted rehabilitation. But the fusion is permanent. The mobility she lost cannot be restored, and the adjacent joint degeneration that the research predicted is progressing exactly as the data suggested it would. The question I ask every patient referred for spinal fusion is the same one I asked Barbara before her surgery, and the same one she wishes someone had asked her before she made her decision. Have you completed a genuine 90-day trial of core strengthening, anti-inflammatory treatment, and nerve support supplementation under proper supervision? For the overwhelming majority of patients presenting for spinal fusion consultation, the answer is no. The referral came before that trial was completed or before it was attempted at all. Surgery number 3, gallbladder removal for silent gallstones. Cholecystectomy, the removal of the gallbladder, is one of the most commonly performed surgeries in America, with over 600,000 procedures annually. And here is the aspect of this surgery that concerns me most for people over 60. Research shows that approximately 40% of people over 60 develop gallstones at some point, but most of these stones never cause problems. Studies have found that only about 20% of people with gallstones ever develop symptoms. The remaining 80% have what medicine calls silent gallstones, stones that sit quietly without causing pain, inflammation, or any functional impairment. Many seniors are told they need their gallbladder removed simply because an imaging scan found stones, even when those stones are causing no symptoms at all. Your gallbladder has a function. It stores and concentrates bile, which is essential for digesting fats and absorbing fat-soluble vitamins A, D, E, and K. Remove it, and your body loses that concentrated delivery system permanently. A 2021 study found that 47% of patients who had their gallbladder removed experienced chronic digestive problems afterward, specifically diarrhea triggered by fatty meals, persistent bloating, and difficulty absorbing fat-soluble nutrients. For seniors, malabsorption of vitamins D and K in particular has direct consequences for bone density and cardiovascular health. If you have gallstones with no symptoms, the answer supported by evidence is not surgery. It is dietary modification to prevent those stones from growing or becoming inflamed. Increased fiber, reduced saturated fat, adequate hydration, and bile-supporting compounds like dandelion root and milk thistle. Preserving a functioning organ that is causing no problems should always be the priority when alternatives exist. Margaret was 72 and had been told during a routine abdominal scan that she had multiple gallstones and should have her gallbladder removed preventively. She had 0 digestive symptoms, no pain, no bloating, no discomfort after meals. When she came to me, I asked her a straightforward question. "Are these stones causing you any problem right now?" She said no. I told her that 80% of people with silent gallstones never develop symptoms, and that removing a functioning organ to prevent a problem that has an 80% chance of never occurring is not a calculation that favors surgery. She declined the procedure. 2 years later, she remains asymptomatic, digesting normally, absorbing her nutrients, and still in possession of the organ she was born with. Surgery. 2. The heart surgery that steals your memory. This is open heart surgery. Your chest is opened, your heart is stopped, you are connected to a bypass machine, and blood vessels harvested from elsewhere in your body are grafted to route blood around blocked coronary arteries. For patients experiencing unstable angina or acute cardiac events, bypass surgery is genuinely life-saving. The concern I want to address is the recommendation of this procedure for stable angina, chest discomfort that is predictable, managed with medication, and not worsening. James was 74 and had been managing mild, predictable chest discomfort with medication for 2 years. His cardiologist told him he needed bypass surgery before something bad happens. He scheduled it. 3 days before the surgery date, he came to me for a second opinion. I reviewed his records. His angina was stable. His cardiac ejection fraction was 52% within normal range. He walked 2 miles every morning. I recommended he cancel the surgery and instead implement a comprehensive conservative program, targeted lipid management with supplementation, anti-inflammatory nutrition with omega-3s as the foundation, structured exercise rehabilitation, and stress reduction. 6 months later, his angina episodes had decreased by 60%. His lipid profile had improved substantially. His energy was better than it had been in 5 years. He told me, "I almost let them crack open my chest. I cannot believe how close I came." The research supports this outcome. The landmark COURAGE trial published in the New England Journal of Medicine followed over 2,000 patients with stable coronary artery disease. Half received bypass surgery or stenting, half received optimal medical therapy. After 5 years, there was no difference in death rates or cardiac event rates between the two groups. For stable angina, invasive surgical intervention provided zero survival benefit compared to medication and lifestyle modification. There is an additional risk specific to older adults that deserves explicit mention. Studies show that up to 50% of patients over 70 experience measurable cognitive decline following open heart surgery, likely related to time on the heart-lung bypass machine. Some recover fully, many do not. This is not a rare complication footnoted in small print. It is a documented outcome in roughly half of older surgical patients. It is also a risk that is almost never mentioned in the consultation that leads to the decision. William was 71 and came to my practice 8 months after bypass surgery for stable angina. His chest pain had improved, but his wife had accompanied him, and she did the talking for the first several minutes because William was struggling to find words mid-sentence in ways he had not before the surgery. His cardiologist had mentioned a small risk of cognitive effects during the consent process. 8 months later, William was experiencing them daily. His family was managing. He was not the person he had been. His angina, which had been stable and manageable before surgery, had been treated. The cost had not been disclosed in terms he had understood when he signed the consent form. Before I get to the most important surgery on this list, one quick thing. If this video is giving you information that changes how you think about a decision you or someone you love is facing, please subscribe. We publish every week. It costs nothing and it means you will not miss the next video. Subscribe now and let's finish this. Surgery. 1. The truth about hip replacement. Nobody tells you this is the surgery that concerns me most for people over 60 because it is the most commonly performed, the most aggressively marketed, and the one whose long-term consequences are most consistently underrepresented in the surgical consultation. Over 450,000 Americans have hip replacement surgery every year. The majority are over 60. The procedure is exactly what the name describes. The ball of the hip joint is removed. The socket is reamed out. A metal stem is hammered into the femur, and an artificial ball and socket are installed. You have an entirely artificial joint. That artificial joint has a documented lifespan. Research shows that modern hip replacements last an average of 15 to 20 years. For someone who has this surgery at 65, that means revision surgery at 80 or 85. Revision surgery, removing the old implant and installing a new one, is substantially more complex and riskier than the original procedure. A 2022 study found that revision hip surgery in patients over 80 carries a complication rate of 28%. That includes infection, dislocation, fracture, blood clots, and death. Patricia was 69 and loved hiking. Hip arthritis was making her trails difficult. Her orthopedic surgeon showed her imaging and said she needed a new hip. She came to me conflicted. I asked her one question: Can you still do the things that matter most to you, even if they are harder than before? She thought for a moment. Yes. It hurts, but yes. I told her to hold off. I designed a specific program, glucosamine sulfate and chondroitin for cartilage support, curcumin for inflammation, targeted hip strengthening exercises to stabilize the joint, swimming and cycling in place of high-impact hiking, and weekly acupuncture for pain management. 3 months later, she was back on the trails, moving more slowly than before, but back. I almost traded my real hip for a metal one, she told me. Thank you for giving me another option. A study published in the journal Nutrients found that a combination of glucosamine, chondroitin, and collagen supplementation reduced hip pain by an average of 43% within 12 weeks in patients with moderate osteoarthritis. Another study found that daily low-impact exercise combined with omega-3 supplementation produced pain reduction equivalent to anti-inflammatory medication without the gastrointestinal risks. Here is what is not disclosed in the consultation. Hip replacement permanently alters your mechanics. You cannot cross your legs, you cannot squat fully, you cannot pivot aggressively. There are permanent movement restrictions for the rest of your life, and for someone with moderate arthritis who has not exhausted conservative options, those permanent restrictions are being accepted before they are necessary. What to do before you agree to any surgery? If you have been told you need any of the surgeries discussed today, these are the steps that the research supports before making an irreversible decision. Get a second opinion from a physician who does not benefit financially from your surgical decision. Not another surgeon in the same practice. An independent physician with training in both conventional and integrative medicine. This single step has changed the outcome for more patients in my practice than any other intervention I have ever recommended. The physician recommending surgery has a financial relationship with that recommendation. The physician providing a second opinion does not. That difference in incentive structure produces meaningfully different advice. Ask 5 specific questions at every consultation. What happens if I wait 6 months and try conservative treatment first? What are the specific complication rates for someone my age, not the general population average? What percentage of your patients experience complications you did not mention during the consultation? Will this surgery improve my lifespan or only my symptoms? What conservative treatments have not yet been fully tried? If a surgeon becomes defensive, dismissive, or uses fear language in response to these questions, that response itself is information. A surgeon confident in their recommendation and honest about the evidence will answer these questions directly. One who cannot may be operating more from habit and financial incentive than from a careful individual assessment of your specific situation. Commit to a genuine 90-day conservative trial before agreeing to any elective procedure. 90 days of consistent supplementation, targeted movement, anti-inflammatory nutrition, and appropriate pain management. The body's capacity to respond to the right support consistently surprises people who have been told surgery is their only option. The supplement protocol that has shown the strongest evidence across the joint conditions discussed today, glucosamine sulfate 1500 mg daily, chondroitin 1200 mg daily, curcumin 500 mg twice daily with black pepper for absorption, and omega-3 fish oil 2 to 3 grams daily. These are not supplements that produce dramatic overnight changes. They are compounds that support the biological processes of cartilage maintenance, inflammation regulation, and tissue repair over weeks and months. The 90-day commitment is not arbitrary. It is the minimum timeline for these mechanisms to produce measurable output. The movement protocol, 20 to 30 minutes of low-impact activity daily. Swimming, cycling, tai chi, and gentle yoga all maintain joint mobility and build the supportive musculature that reduces mechanical load on damaged joints without the impact that aggravates them. Pain should guide intensity, not eliminate movement. Gentle, consistent movement is anti-inflammatory. Extended immobility accelerates exactly the deterioration that makes surgery seem necessary. Within 3 days of consistent anti-inflammatory supplementation, most people notice reduced morning stiffness. Within 2 weeks, measurable improvement in range of motion with daily movement. Within a month, pain levels that have been chronic and accepted begin to shift in ways that change what surgery feels necessary. Within 3 months, the cumulative effect of cartilage support, inflammation reduction, and strengthened supportive musculature produces outcomes that regularly prevent the surgical procedures that seemed inevitable at the start. 3 mistakes that lead people to unnecessary surgery. First, accepting a fear-based timeline. If a surgeon tells you that you need this now or you will be in a wheelchair, get another opinion before that sentence determines your decision. Urgency language in an elective surgical consultation is a pressure tactic, not a medical finding. Second, treating pain as an automatic surgery indication. Pain is your body communicating. It is not always communicating that you need an operation. It is sometimes communicating that a joint needs better support, that inflammation needs to be addressed, or that the muscles stabilizing a structure need to be strengthened. Third, assuming conservative treatment means accepting suffering. Evidence-based conservative management is not resignation. It is the appropriate first intervention for most of the conditions that lead to these surgical referrals, and the research consistently shows it produces outcomes comparable to surgery for the majority of the patients on whom it is tried. Barbara cannot get her full mobility back. The fusion is permanent, and the adjacent joint problems that developed are the predictable consequence the research warned about. James still walks 2 miles every morning with his chest intact and his angina reduced by 60%. Patricia is on the trails. The difference between those 3 outcomes was one decision, made at different points relative to an irreversible procedure. Barbara made her decision before she had seen the research. James and Patricia made theirs after. You are seeing the research now. Leave a comment telling me which surgery on this list surprised you most, or whether you or someone you love has faced one of these recommendations and what happened. Your comment helps other people in this community understand that they have more options than they have been told, and that asking questions before surgery is not difficult or confrontational. It is the most responsible thing you can do. If this video gave you something useful, share it with someone facing a surgical decision. The conversation you start could be the reason they ask the questions they need to ask before it is too late to ask them. I'm Dr. Jake Taylor. Subscribe if you have not already. Take care of yourself, and I'll see you in the next video.